confirm live.
You can just confirm. Thank you. Hello, and a very good evening to all. I, Dr. Dhamdeep Dabade, on behalf of MQ Pharmaceuticals Limited, welcome you all on the occasion of Hypertension Therapeutics Conclave, Module 6. Hypertension Therapeutics Conclave is the legacy program of MQ since last decade, and this program is meant to update with the recent trends in the area of hypertension with the experts in the field. Today, we are having the sixth and the last module of the series based on a topic, hypertension in chronic kidney disease, the novel insights. To discuss and to have the opinions ahead, we do have the panel of experts with us today. To direct throughout this particular event, we do have our course director with us, Professor Dr. G.S. Wonder, sir. It's my privilege and honor to introduce Professor Dr. G.S. Wonder, sir. He is the Professor of Cardiology at Dayanand Medical College and Hospital, Ludhiana, Punjab, India. He has been published with over 210 papers, 96 of them in foreign journals of repute like the Lancet, etc. He is the Director of Physician Research Foundation of Association of Physicians of India for the year 2022-2025. Been the President of the Association of Physicians of India, been the President of the Hypertension Society of India, been awarded with Dr. BCI National Award for the year 2006, and been the editor of the cardiology section of the API textbook of medicine. With that note, I would like to just hand it over Professor G.S. Wonder, sir, to take the discussion ahead, and please take the proceedings ahead. Thank you.
Thank you, Dhamdeep, for this lovely introduction. And as we are all going through the third wave of COVID-19, I welcome you all the delegates to the sixth in a row webinar on management of hypertension that we've had. You all know Dr. Matthew Wire. He's delivered the previous 4 talks, and it's been actually an excellent experience for me. I have learned enormously so many issues regarding hypertension, what the evidence base is, and Dr. Wire also gives in his clinical experiences and his clinical approach to management of hypertension, and that is one other very useful aspect which we have learned so much. He's probably kept the best for the last webinar, because as you know, he's a professor and director of Division of Nephrology in the Department of Medicine at the University of Maryland. And being a nephrologist with special interest in hypertension, today he's actually going to speak upon the hypertension in chronic kidney disease. What are the novel insights into it? He's, of course, as you all delegates, my friends, you all know, he's contributed more than 600 manuscripts, 8 books, and he's a reviewer to most of the medical journals of nephrology and hypertension. He's on the editorial board of 18 journals, and he's truly a very distinguished researcher, clinician, expert, and a great speaker. So we are lucky to have Dr. Matthew Wire as the main speaker. We are also very lucky to have 3 very distinguished clinicians from across the country, I would say, because we have Dr. Tiny Nair from down south, Dr. Deodatta Shefekar from west, from Nasik, and from the east we have Professor Shubhankar Chaudhary, and of course myself from north. So we truly have a transnational representation today. Dr. Tiny Nair is a personal friend of mine. We all know he works in the PRS hospital in Trivandrum, Kerala. He's one of the best doctors award he's had. He's an inspirational doctor. Economic Times delivered him the inspirated doctor of the country. And he's been a reviewer to multiple journals across the world. He's a member of the Hypertension Council of the Cardiological Society, a great orator, expresses medicine evidence very succinctly and very clearly, authored 5 books. One of his books on statistics, I learned my basics in statistics from Dr. Tiny Nair's book. And his latest book is Magic of Indian Medicine. He writes a blog, Cura, and he's a TED speaker. So thank you, Dr. Nair, for being here with us today. Then we have a very distinguished nephrologist from Nasik, from Maharashtra, from the western part, Professor Deodatta Shafekar, who's earlier worked actually in Grant Medical College and States GS Medical College. He's a vice president of the Indian Society of Nephrology, ex-president of the Indian Society of Nephrology, the West Zone chapter. He's the editor-in-chief of Journal of Maharashtra Association of Physicians, a very distinguished nephrologist, professor of medicine at Dr. V. Pawar Medical College, Nasik, and works at the Supreme Kidney Care Hospital in Nasik. So it's a pleasure to have you, Dr. Deodatta, with us. Then we have an endocrinologist, a distinguished endocrinologist from the eastern part of India, from Kolkata. Dr. Subhankar Chaudhary is professor and head of endocrinology at the prestigious IPG MER Hospital, Kolkata. And he's been a past editor-in-chief of Indian Journal of Endocrinology, a past president of Endocrine Society of India, and an immediate past president of Endocrine Society of Bengal, more than 200 publications. And so we have a very distinguished panel from across the country. And over to Dr. Matthew Weir to take us through today's topic of hypertension and chronic renal failure. Dr. Matthew Weir, please.
Well, good evening, and it's a great pleasure to be here again. I've enjoyed very much the opportunity to work with you and to discuss so many different and important topics in the field of hypertension, which, as we know, is a very important area of our clinical commitment to our patients. I've entitled my brief lecture today, Hypertension and Chronic Kidney Disease, Novel Insights. And there are really two parts to this. The first part will be to delve into the issue of hypertension due to the kidney itself. And here I'll be focusing both on renal parenchymal hypertension, but more importantly on renal artery disease. And then the second part of my lecture will discuss more of the clinical conundrum that we face with regard to choosing blood pressure goals in people with chronic kidney disease, and whether they should be the same as in patients without chronic kidney disease. Here are my disclosures, none of which are relevant to my presentation this evening. And so here are what we'll touch on right now, and that is blood pressure and the kidney. We'll look at the whole issue of secondary hypertension, renal artery disease, and then talk a little bit about the blood pressure goals. You know, I think it's important to remember that the whole issue that of choosing blood pressure goals in people with chronic kidney disease is really based on important understandings about the glomerular vascular beds. It's hard to believe we have anywhere from 700,000 to 1 million of these filtering units. But they like to operate at about 1/2 to 2/3 of systemic blood pressure. And consequently, we need afferent arteriolar vasoconstriction to step systemic pressures down to ideal filtering pressures for the glomerulus. We also have an efferent arteriole, which can vasoconstrict during states of diminished effective arterial blood volume, thus maintaining the necessary pressure for filtration. Now, these two vascular beds working in concert are very capable of auto-regulating blood supply to the kidney to be sure of adequate function. The problem comes with aging, high blood pressure, and diabetes, where there is damage to these arterioles, and particularly important, the afferent arteriole, where the damage may limit the autoregulatory response, thus making the kidney's filters more vulnerable to the effects of hypertension. And it should not be surprising to you if you look at experimental models in rats of the percentage glomerulosclerosis that occurs relative to blood pressure, that there is a clear correlation, linear. You'll also interestingly note that drugs that modify the activity of the renin-angiotensin system also appear to be more effective in limiting glomerulosclerosis at higher blood pressure levels, which does not mean that these drugs, if you use them as an excuse not to lower the blood pressure enough, but it does start to explain why they do have inherent renoprotective capabilities, which are explainable based on their effects on glomerular hemodynamics. And again, lowering not only systemic blood pressure, but dilating the efferent glomerular arteriole. So with that background, let's talk a little bit about identifiable causes of hypertension, which are related to the kidney, and obviously those in large part related to the adrenal gland. Now, we've already touched on resistant hypertension in a prior lecture, so I'm really not going to focus in that area. I'll touch primarily on the kidney today and focus our conversation in areas beyond what we've already touched on here, which are some of the many secondary causes of hypertension. And as we've discussed previously, aldosterone really is the big one with regard to secondary endocrine causes. But our focus today is the renal artery. Now, let's agree renal artery disease is as common as coronary disease. So I think the bottom line is, it's a lot of it's out there. The real question is, when is it clinically relevant? When does it really contribute to the development of essential hypertension? Probably not often. But it may be a bit higher in people with very severe or resistant hypertension. So it's always part of our understanding to exclude it as part of our workup in those types of patients. And of course, bilateral disease is much more common in people with a lot of blood vessel disease elsewhere in the body. Now, there are two major causes of unilateral renal artery disease. One obviously being atherosclerosis, typically in older patients. But again, in younger people, you may have fibromuscular dysplasia. And interestingly, it tends to be more gender-oriented towards women and in younger people, and involves the distal aspects of the main renal artery or even intrarenal branches. So if you look at the clinical picture, I've described this here in a series of tables. And what I think is important to realize is that depending on the age of the patient, that's really a good clue to you whether it's atherosclerotic or fibromuscular hyperplasia. But I think one of the good clinical clues for us in practice is when we use an ACE or an ARB, if you see more than a 30% increase in serum creatinine, that should raise some consideration about renal vascular disease. But it could also indicate volume depletion or use of a non-steroidal anti-inflammatory drug. So I think it's up to us to make sure we go through all three possibilities. And testing is warranted in people who fulfill these criteria that you see here. And what's also important to understand is that interventions are to a certain degree controversial depending on the clinical circumstances, which we'll talk more about that. A little bit more about diagnosis. Because of the potential harm for invasive procedures, we should only test those people who have a very high likelihood of getting a benefit from an interventional process. And you can see some of those listed here, including short duration, failure of optimal therapy to work, intolerance, worsening kidney function is important. And of course, fibromuscular dysplasia, which is curable, and rarely recurrent flash pulmonary edema or heart failure. There are a number of different testing options. In part, it depends a lot on where you work and the imaging techniques that are available and the people that interpret them. By far and away, if the body habitus is adequate, Doppler duplex ultrasonography is probably the easiest and least invasive. But again, you need to work with your imaging people to really decide what test is best. You really need a proper body habitus. People who are very overweight may be much more difficult to really examine the vascular function with duplex Doppler, unfortunately. But again, it's safe, it's simple, it's relatively inexpensive, and you can use serial measurements of it. But the disadvantages are it can be time consuming and it's technically difficult in people who are overweight. And you have to have somebody who's quite good at doing it. It's not something you just have anybody look at. It's got to be somebody who's had some experience. And again, a positive test is more informative than a negative test. Spiral CT or CT angiography does require contrast. And again, there's always a risk there, albeit small. And it's highly accurate test, but less so for fibromuscular dysplasia. So again, the age of the patient can help discriminate that. CT angiography combines a little bit of the best of both worlds. And you can see it's quite sensitive and specific. MRA with contrast is another option if it's available. It's also highly sensitive for detecting proximal lesions. There are a number of studies that have shown that. Again, it depends on what's available in your institution and hospital and the people, obviously, to interpret the results. But you can see it's quite sensitive and specific. I think it's important to remember, though, that if you have a younger patient, non-invasive imaging is much less reliable. And in large part because the lesions tend to be more distal and possibly even intrarenal. And so the sensitivity drops down a lot. You really need to move on to MR or CT angiography under the circumstances. Renal vein renins have a limited role in estimating the physiological significance, especially in people who may have bilateral disease. Probably best to focus more on imaging rather than renal vein renin measurements. There's no right way in everybody. The optimal way to deal with these types of patients is, it's going to have to be carefully individualized. But I think probably the biggest concerns are listed at the bottom of this graphic here. And what I think is probably most common is whether or not people either have uncontrolled hypertension or progressive declining kidney function as you treat their blood pressure to a lower level. And once a patient has a high probability of having this based on the clues I just discussed, there are really three different strategies to consider. Medical therapy, we should be doing in everybody. I mean, that goes without saying. Whether or not you want to do invasive percutaneous or open surgical approaches requires a lot of careful consideration. And, again, it's going to depend a lot on those patients who you suspect are going to have a very high likelihood of benefiting from the intervention. And I've listed 4 of those shown here. But you have to be careful because, as I will discuss, the data with interventions is not as rosy as we would like it to be. And, there have been a lot of studies to look at this, of which the biggest was a study called CORAL. You can see what the acronym means there. This was a government-funded study done in the United States. And as you can see, to really examine whether people will benefit from a percutaneous renal angioplasty or percutaneous angioplasty with medical therapy versus medical therapy alone. And you can see the inclusion criteria listed here. It was quite a large study, really the largest one ever done. And everybody had to get, antiplatelet therapy and, appropriate treatment for blood pressure, cholesterol, glucose. And then again, randomized to either get, obviously, and a percutaneous intervention with stenting or nothing. And the bottom line is revascularization plus medical therapy had no effect on the primary outcome compared to medical therapy alone, 0. So you really have to consider this carefully. And then the other issue is, there were more serious adverse events in people who were revascularized compared to those who weren't. So, the reality is this is common. It is mostly associated with atherosclerotic cardiovascular disease. It rarely requires percutaneous intervention unless really you're having problems losing kidney function. And really, you almost very aggressive global cardiovascular risk reduction measures are really the way to go. So, and careful individualization of those who need revascularization. All right. Enough on that. Let us turn our attention now to blood pressure goals in people with chronic kidney disease. First, I want to emphasize is there's not a lot of data, believe it or not. If you look at studies with people with really stage 4 chronic kidney disease, or even some stage 3B, meaning basically people less than 45, there are only 3 randomized controlled trials looking at 2 levels of blood pressure reduction in people without diabetes. And for the most part, they were small without a lot of longitudinal follow-up. But what was clear is that people with more proteinuria did benefit from a lower blood pressure goal. Surprisingly, there are no randomized controlled trials looking at different blood pressure goals in people with diabetes. I know you're going to find that surprising because there's lots of talk about it, but it's really the secondary analyses of these studies which really provide perspective for us that there is good consistency to show that lower levels of blood pressure, preferably below 130, does appear to provide protection against loss of kidney function. And I'll give you an example of that. This is the irbesartan diabetic nephropathy trial. People who started out with a GFR of about 50 with a fair amount of protein in the urine. And they were randomized, as you will recall, to either irbesartan, amlodipine, or placebo. And, the bottom line is the angiotensin receptor blocker provided a 20% relative risk reduction benefit. Okay, but we're not looking at that here. What we're looking at here are where did people end up depending upon where their blood pressure was during the course of the study. And quite clearly, those with lower levels of achieved blood pressure did quite a bit better, and much fewer patients developing a doubling of serum creatinine or reaching end-stage renal disease. So this is the type of secondary analysis that we have. And here's another aspect of that same paper, looking at the natural log of the relative risk for reaching a renal endpoint by achieved systolic blood pressure. And again, it does suggest that getting down into the 120s makes sense. But again, this is all inferential. It's not a prospective randomized controlled trial to purposely lower people there. So, the results of these types of observations, and I'll show you some other, just a couple of other controversial papers here, that causal inference, meaning suggesting that lower levels of blood pressure are appropriate, does require proof from, interventional studies. You've got to do more than just observe it. And there has to be biological plausibility, which we have. I mean, it does make sense. And that evidence that reversal of the risk factor, that is the blood pressure, does make a difference. But let me just share with you again some of the difficulty in interpreting the data. And I'll share with you too the mounting evidence that the observational association of systolic blood pressure with mortality in people with chronic kidney disease and ESRD might be a little bit different than people with normal kidney function. And it raises the question, do we need somewhat different goals in people with chronic kidney disease or those, for example, on dialysis? And we don't have a complete answer yet, but we are getting more suggestions from the literature. But let me show you what we have today. So this is a very large analysis of a Veterans Administration database in the United States, comparing blood pressure treatment and goals in two different groups, one of whom in blue is treated to about 130/72, and the other treated to what? About 118/68 or so. If you look at the Kaplan-Meier survival curves, it suggests that blood pressures below 120 are actually associated with less survival. Again, it's observational data, but again, raising question about whether or not lowering blood pressure too much is bad for you. Or you could say, gee, are people with much lower blood pressure sick from something else, like heart failure, for example? But again, that's the difference between observational data and interventional data, which we don't have a lot of. And you can see here, when those investigators looked at all the different demographic factors, it did show that having a blood pressure below 120 was associated with more hazard. All right. And more to that, here is again the other problem that we face. There are many fewer people with blood pressures below 120 compared to those above it. And if you look specifically at people with lower GFR, and this is coming from the Crick cohort, you will see, interestingly, we don't really have much of a U-shaped curve compared to what I shared with you on the previous slide in the general population. So the general population looks worrisome if you go below 120, but it doesn't appear so here. But if you look in this database, and again at eGFR in the middle here, less than 30 or greater than 30, it doesn't look too much different. So there's a bit of controversy depending upon the data sets you look at. More on that, here's another very large analysis done by a British research group from the SHARP study. Again, that was the study about lipid lowering in people with chronic kidney disease, about 9,000 people, a third of whom were on dialysis. Now here, if you look in the upper left-hand corner for systolic, it does suggest that once you start getting lower towards 120, there might be a little bit of a U there, more so for the diastolic. But if you look at the pulse pressure, it seems pretty linear. All right, lower pulse pressure is better for you. But now what these investigators did, which I thought was very interesting, was to break the data down and focus on those with or without prior cardiovascular disease. And what I think is most interesting to note, if you just focus in the first two panels on your left, numbers A and numbers B, is that if you look at people with cardiovascular disease as shown in A, and compare that to people on dialysis down here in B, look how different the curves look. It's pretty amazing. All right. And again, possibly suggesting that people in the top panel without kidney disease, you need to be careful if you go below 120. Whereas if they have kidney disease, there's not as much of a concern. So they actually do look a little bit different in that regard. So the presence of a clear relationship between systolic or pulse pressure and cardiovascular events in people with chronic kidney disease, even at lowest risk of cardiac disease, suggests that maybe there is what we call reverse causality, and that is the people with more cardiovascular risk with blood pressures at lower levels, below 120, may be explainable by the fact that they have heart disease. And that may really be the issue to explain the U, so to speak. And obviously, that may be the explanation here. So, with all that controversy in the background, let me provide perspective with the SPRINT study, which is really the only huge study, although more recently there's also a Chinese SPRINT study, which showed very similar results. But this is a study, as you will recall, comparing 120 versus 140. But again, remember, it used automated measurement of blood pressure that was unattended. And that typically gives readings which are a bit lower than what we see with typical office-based measurements. So the intensive treatment goal was probably around 127, whereas the standard treatment was probably in the mid-140s. But you'll also remember, too, these people did not have kidney disease, because when your mean age is around 70 and your mean GFR is around 70, that's pretty typical for that age range. And no proteinuria. And you'll remember the follow-up separation was quite good, and that there was a clear advantage from a cardiovascular standpoint to limit heart failure and cardiovascular events, but not kidney events, as you can see here. And I think in large part, we have to remember that you're not going to see a lot of kidney events in people who don't have kidney disease to start with. And so the number of events is tiny. And so there's really no possibility for discrimination in this regard. So I think much of the, shall we say, poo-pooing of the observations with regard to the kidney have to be kept into perspective. And that is, if you go back to the real result of the study, it's this. This is what the study was powered to look at. It was not powered to look at kidney disease. And yes, there was a slight decrement in eGFR in the intensive group, largely related to the greater use of thiazide diuretics and ACE inhibitors in the more intensive treated group. So I think the bottom line is, if you look at the SPRINT study, it did not show a benefit of a lower blood pressure goal, except that you live longer because you have less heart failure and less cardiovascular events. So again, even this study does not provide an answer to our question as to what is the best blood pressure goal. So I would summarize this part of our conversation by stating that no two people are alike. I don't know that we have a perfect blood pressure target, other than to say less than 130 makes a lot of sense in people with or without kidney disease, based on all of the available data we have to date. In people with kidney disease, is the right blood pressure goal associated with reduction in proteinuria? Maybe, probably is. And that might be a clue that we're doing the right thing for our patient, is if the proteinuria goes down. Of course, reducing CV risk, of course, slowing the loss of kidney function over time. And I think bottom line is the weight of evidence suggests that lower blood pressure targets are advantageous in everybody, and that randomized studies are the only way to control for the residual confounding that occurs in observational data like I shared with you. So with that being said, I will conclude my presentation, and I'm welcoming questions, comments, and obviously other people's interpretations of this data.
Thank you, Dr. Matthew Wire, for that very explicit description of the evidence base that we have with regards to renal involvement and hypertension. And I must say, as an interventional cardiologist, I totally second your observations that renovascular hypertension is something that should be investigated only when we are anticipating an intervention. And if I recollect 10 years back, before the CORAL study, when we used to do interventions from the femoral route, a lot of us cardiologists used to look at the renal vessels, and we almost used to do renal angioplasty once or twice a month at that time. But ever since the publication of the CORAL study, I haven't done a renal angioplasty for the last 1 year. So the number of interventions after the CORAL and the previous Astral study on the renal, because we today know that the medical management is as good as intervention in patients who have renal artery stenosis. But he very beautifully said that people who have deteriorating functions, who have flash pulmonary edema due to bilateral renal artery stenosis, that's something where we need to still have a place for the renal interventions and stenting of renal artery stenosis. The second aspect Dr. Matthew Wire touched upon is a very important aspect, which is of value to any hypertension expert, because of the fact that we had the SPRINT trial and we now look at blood pressures targets which are lower than the ones that we wanted to achieve earlier. And as a cardiologist, we always say there is a disparity in terms of benefits that the cardiac vascular and the cerebrovascular system gets with a better control of blood pressure. And as they say so explicitly, as we come in the human body from above downwards, the maximum benefit of blood pressure control is in stroke reduction, and then of course cardiovascular events significantly. And he did touch upon patients who have stage 3B or 4 renal failure as to what is how strongly should we trying to reduce the blood pressures. And that's possibly the reason that the European guidelines now have given a lower level of blood pressure also, that don't go below 120 even otherwise, and 70 diastolic. Diastolic more for cardiovascular, non-revascularized patients. And so Dr. Matthew Wire discussed in detail the various aspects of how much we need to, and obviously we need to treat a human being in totality, and we don't look at organ systems, although we have experts today of each of the organ system, and I would like to involve actually each one of them one by one. Dr. Tiny Nair, I would like to know from you, Dr. Wire has discussed this issue of the cardiac and renal involvement in hypertension. And we all know cardiorenal syndrome is an entity which occurs in acute renal and acute heart disorders, and also in chronic renal and chronic cardiac. So tell us, bring the cardiac angle to this whole discussion that we are having regarding hypertension and renal failure, in terms of what is cardiorenal syndrome, how does it influence our choices. Dr. Tiny Nair, please.
Thank you, sir, and thank you, Dr. Ware, for that excellent presentation of opening up an entirely new aspect of thinking on hypertension and target organ damage. And like Dr. Wonder said, it's a very complicated area when we try to talk about so-called cardiorenal syndrome. Basically, cardiorenal syndrome, for the large number of physicians who are participating, it's a cardiac disease coming in, which leads on to a renal disease, cardio-renal. And we are not very sure as to how they're connected, right? Now, if there's an acute cardiac event, let's say an acute myocardial infarction, an acute coronary syndrome, or maybe an arrhythmia, or maybe myocarditis, sudden onset, And if that leads on to an acute renal failure, we call it an acute cardiorenal syndrome. And that's what is called the so-called type 1 acute cardiorenal syndrome. If we have a chronic heart failure, a patient who is known to have heart failure for a long period of time, and as time progresses, his renal parameters are worsening, we call it a chronic cardiorenal syndrome, what we call as the type 2 cardiorenal syndrome. So type 1 is acute and type 2 is chronic. And the reverse is also true. You can have a renal failure to start with, and who can develop a cardiac failure over time, so-called renal cardiac syndrome. Again, if it's an acute onset, acute kidney injury, and followed by cardiac, it's type 1, type 3, and if it is like chronic renal going on to chronic cardiac is 4. So acute, chronic, first heart or first kidney. But the problem is many often we might get a case who already has an evolved cardiac failure and a renal failure and not really knowing as to which came first and how to label it. But the point is, we were looking at, let's say, echocardiogram showing an abnormal left ventricular function, okay, or an elevated NT-proBNP as a cardiac failure. And on the other side, we were looking at kidney. We were looking at the worsening of creatinine over time, GFR worsening as the kidney failing or going on to maybe a renal replacement therapy or renal death, whatever. Okay, that used to be the kidney parameter. But subsequently, we realized that probably we need to go deeper. In fact, today we are looking at a much, much deeper picture where we say that, let's say in heart, you have this loss of myocyte and slowly being replaced by fibrous tissue, right? So the myocyte fails, the functioning component fails, and you have a lot of fibrosis. In the kidney, similarly, the functioning component, the glomerulus and the tubules fail, and you get replaced by fibrosis. So what are we talking about? Perhaps there's a connecting link, and yes, there is. So if we look into a bigger picture, the driving forces like an abnormal renin-angiotensin axis and higher aldosterone system, or an altered neprilysin axis, the vasodilators as a whole, or an abnormal sympathetic axis might be responsible for damage to both the heart and the kidneys, right? And today, that is what we are trying to. So if we are looking into the therapy segment, the problem of therapy of a cardiorenal syndrome is that half the drugs that we use in cardiac, we should be very careful in renal. For example, like Dr. Matthew said, that if our creatinine is rising up more than 30% on exposure to an ACE-ARB, we are thinking of a renal artery stenosis. Now, our patient might already have an altered GFR. It might be difficult or challenging to start him on an ACE or ARB. And we know that starting is very vital because that decision to start might prevent his cardiovascular disease in the long run because he has a cardiac failure too. So the challenge is how to start. I mean, that is important, but we should now realize that we are now going from ACE to ARB and onto ARNIs. A lot of subset data coming out from Paradigm HF that and the Paragon that probably those with an already altered renal parameter might benefit probably in a better way in slowing down of the worsening of the kidney function by an ARNI compared to an Unilateral alone. Similarly, we are now talking about SGLT inhibitors, which as a large part not only elevates the heart, but also elevates the kidney. Okay, take beta blockers. I mean, many of the drugs, as we go on to a stage 3 or a stage 4 kidney failure, they tend to lose their effectivity in reducing event rate. But beta blockers continue to be beneficial. So we are talking about an abnormal sympathetic system, we are talking about abnormal renin-angiotensin system, and an abnormal aldosterone milieu. And we are trying to tackle all that individually. I think it's very challenging, and we have to see each patient as to how he tolerates this therapy and decide as to each stage, each type, what therapy would be the best for him.
Thank you, Dr. Tiny. I think you really emphasized very beautifully something what Dr. Wire said regarding the kidney, that initially there is a vasoconstrictive element and abnormality in the renin-angiotensin and the sympathetic system. And similarly, you did emphasize that in the heart also, there is initially left ventricular hypertrophy and subsequently it goes on to develop fibrotic changes in the heart, influenced obviously by the cascade of neurohormonal changes that are seen in hypertension and also in renal failure. And that does emphasize as you are trying to discuss with the audience, that if we intervene early in this whole gamut, we will be imparting greater benefits to our patients. Once patients have already developed, so to say, atrial fibrillation or hypertensive heart disease, or as Dr. Matthew Weir was saying, a decreased GFR, half of the battle is already lost, and because pathologically, anatomically, changes have developed which are non-reversible. So an aggressive approach in the early stages is something which is very desirable, and that you and Dr. Weir have so beautifully actually emphasized. We'll have Dr. Weir's comments on all three experts' feelings, because some very challenging thoughts from you, Dr. Tiny. We have Dr. Subhankar Chaudhary, who's a distinguished endocrinologist, and we all know in this country, diabetic nephropathy is the commonest cause of chronic renal failure. And so to say, Indian endocrinologists deal with diabetic nephropathy. So tell us something about your thoughts in regarding the targets of blood pressure you want to achieve, Dr. Subhankar Chaudhary. What is your choice with regards to antihypertensive agents in early stage CKD, in mid-range CKD, and in late stages of CKD? And so we would really like to know from you your thoughts on the pathophysiology, how this diabetic nephropathy goes on. Proteinuria has been emphasized so much number of times, and Dr. Matthew Weir also emphasized. This probably tells us the subset of patients who get greater benefit with greater control or use of ACE inhibitors. So give us a perspective to all of us as cardiologists and as physicians. What is your endocrine perspective to this whole problem? Dr. Subhankar Chaudhary, please.
Thank you. Thank you, Dr. Wonder. It's been a great meeting. And thanks to Dr. Weir for actually pointing out the paucity of studies, good RCTs, to actually suggest what should be the ideal blood pressure level in people with diabetes, and also maybe with diabetic nephropathy. Now, diabetic nephropathy, of course, we as endocrinologists, diabetologists, our first endeavor would be to prevent development of nephropathy to the extent possible. And the best means, of course, are blood glucose control and blood pressure control. It's also interesting that at least in type 1 diabetes, the category is possibly there is a genetic predisposition or genetic protection, which of course we do not understand so very well. So that if people have not developed type 1 diabetes, if they have not developed nephropathy, maybe in about 15, 20 years, probably they have less chance of developing nephropathy subsequently. That's an interesting observation. In relation to your specific question as to what should be the blood pressure target, well, the target we would feel, I mean, despite the overall target in diabetes being generally accepted as to be within 140/90, those who have early stage nephropathy, at least, the general tendency to try and keep the pressures even lower than that, maybe 130 would be a better target. And of course, any drug, any antihypertensive will help to slow down the progression. And we do understand the special relevance of not only systemic hypertension, but intraglomerular hypertension. That's another entity that, of course, our nephrologist colleagues would sort of tell us better about. That we need also to control the intraglomerular hypertension, and then therefore drugs like ACE inhibitors or ARBs, which tend to cause efferent arteriolar vasodilatation, therefore work better in relation not only to reducing proteinuria, but also likely to protect renal function over a long term. And now Dr. Tiny Nair has already referred to the SGLT2 inhibitors. That's an additional arm for us, which also reduces intraglomerular hypertension, but by a different mechanism, in the sense that they tend to cause, supposed to cause afferent arteriolar vasoconstriction, thereby decreasing the glomerular hypertension. So this is an additional bow in our arrow in our sling to try and control the progression of nephropathy, even outside of control of hypertension. And today, the other beyond the ACE or ARBs, we do understand the importance of mineralocorticoid receptor antagonists. The problem with their use, especially with renal damage having progressed beyond, let's say, CKD stage 4, is an increasing risk of hyperkalemia. In this context, though, of course, it's not yet available to us in India yet, finerenone could be a very important addition, which has been shown on top of use of ARB to help slow down the progression of diabetic nephropathy. So these are sort of my short overview of this large subject.
Thank you, Dr. Subhankar, for giving us an endocrine perspective into as diabetic nephropathy progresses, what are your targets in terms of blood pressure reduction? And of course, you are keen on reducing the progression of diabetic nephropathy. So what are your thoughts on ACE inhibitors, ARBs, vis-a-vis other blood pressure medicines? We have Dr. Deodatta Shefkar with us. He's a nephrologist of great experience. Dr. Matthew Wire spoke about the two causes of renovascular hypertension, that is atherosclerotic in the elderly and fibromuscular dysplasia in the young women. All of us actually, especially Dr. Subhankar from down east and even we in north, see a lot of aortoarthritis. And aortoarthritis happens to be one of the Takayasu's arthritis, one of the commonest cause of renal artery stenosis in the young people in India. And Dr. Deodatta Shefkar, what are your thoughts on renovascular hypertension, and how do you manage your patients who are on dialysis with hypertension? Since we are discussing, let's have your perspective as to what are your drug choices in early nephropathy, say patients who have proteinuria, how aggressive you are. And as the renal failure progresses, does it make your choice of drugs or aggression in terms of blood pressure reduction, does it make a huge difference? Dr. Debabrata Shefkar, please.
Thank you, Dr. Wonder. And thank you, Dr. Matthew, for that nice talk. And I'll make a few comments first regarding your questions, and then I have some points to discuss with Dr. Matthew. I think you asked me about how do you manage patients with hypertension and kidney disease, and what are your drug choices. So I'll take that first. So of course, the recommendation is very clear that you must use ACE inhibitors and ARBs unless they are contraindicated or you have some side effects related to that. But the important point which Dr. Matthew has brought about is that proteinuria must be quantitated and it should be targeted. And if you are able to target the proteinuria and demonstrate that there is a reduction in proteinuria, that probably is going to give you some indication about both renal protection as well as cardio protection. So the choice of drugs would be ARBs or ACE inhibitors, whatever is tolerated. In our experience, of course, ARBs are tolerated much better than ACE inhibitors in our patients. Followed by, of course, we use calcium channel blockers and diuretics. So that's the general choice of drugs in patients with kidney disease to control the blood pressure. Most of the patients with kidney disease require more than 2 to 3 drugs to control their blood pressure. And if the blood pressure is still not controlled, then of course we have other choices of drugs. I think the MRAs have already been mentioned. MRAs have got some renoprotective effect. However, we are aware about the problems related to MRAs like fall in GFR as well as hyperkalemia. And the recent KDOQI guidelines have in fact mentioned those who were published in 2021 that in resistant or difficult to control blood pressure in patients with kidney disease, sometimes we are forced to use MRAs also. But of course, with a clear understanding that these two parameters have to be monitored. In fact, the potassium binders which have been used or newer drugs for hyperkalemia like petiromor and zirconium have also been used by some people to control the hyperkalemia and use MRAs in conjunction at the same time. We must also remember that the other drugs which are used in resistant hypertension are alpha blockers and sympatholytic drugs, which in our practice we have to use in many patients because it is also known that with the falling GFR, the blood pressure becomes more and more resistant or more and more difficult to control. So as the GFR falls, then sometimes as nephrologists, we have to use multiple drugs. Now, in that connection, it's very important, the point which you brought about the renovascular part. The patients on dialysis, Dr. Matthew mentioned about the flash pulmonary edema. So we have had some patients who are on dialysis and coming up with recurrent flash pulmonary edema. And of course, those patients we investigated and they were found to have a renovascular issue and they were treated subsequently for the same. So that's a very, very clear-cut indication of a patient who is adequately dialyzed, whose volume is controlled, but in spite of that, because of severe hypertension, he develops flash pulmonary edema. As far as aortoarthritis is concerned, I think we are living in the tropical country, so therefore the incidence of aortoarthritis is higher. And even in my student days, I have seen Takayusu's and even non-Takayusu's arthritis. In fact, one of the first publications regarding this was from KEM Hospital, Mumbai, where I studied. And we know that there are younger patients with arthritis who develop renovascular issues, but then they have to be diagnosed early. And all the features by which you suspect a renovascular cause has already been brought out by Dr. Matthew. As far as the atherosclerotic renovascular disease is concerned, I agree with all of you that the reason for intervention has definitely come down after the CORAL trial. And you also mentioned about what I used to call was drive-by angiography. So the incidence of doing that is of course now less. And I think we should always check the renal function, check the proteinuria, do the ultrasound before you think about any renal intervention. And of course, rule out all the other secondary causes of hypertension in people who are requiring those investigations. So to my mind, I think proteinuria should be targeted. The two other important points which I would like to make in discussion with Dr. Matthew are that the targets of blood pressure which he has mentioned. Now the lower the better. That is something which is definitely controversial. Whether we should go less than 120, the KDOKI recently mentioned that in selected patients, probably less than 120 might be useful, especially in those patients who have proteinuria. As he already mentioned, diabetics versus non-diabetics, hardly any literature is there. But in diabetics, the target would be around 130 or less systolic. The diastolic area is slightly controversial. I would like to Dr. Matthew to comment on the diastolic part of the blood pressure, but that is something which there is hardly any literature on that to my mind. So probably the targets are 130 to 120 in selected patients, but the bottom line is individualize your therapy.
Thank you, Dr. Deodatta, for telling us your viewpoints in a very beautiful manner as to how a nephrologist looks at this, and you did discuss all the aspects. May I request Dr. Matthew Wire to just give his impressions on some of the things that I said and Dr. Tiny commented upon, then Dr. Subhankar Chaudhary mentioned, and now Dr. Deodatta Shefkar has asked you. Let's hear your perspective in terms of the discussion that we have had till now. Dr. Matthew Wire, please.
Well, it's hard to remember all the discussion. All the comments were good. A lot of experience here on the panel today. So let me go in reverse order. We'll talk about the diastolic first. Really, diastolic is most important particularly in younger people who have healthy aorta, because it is the aortic recoil which creates the diastolic blood pressure. And obviously, the greater the recoil, the greater the diastolic, the healthier the aorta. But paradoxically, we know the higher the diastolic, obviously, there is risk for blood vessel disease. Thus, people over the age of 55 years, where there is clearly some senescence of the aorta, tend to lose that elastic recoil, and the diastolic naturally, in a sense, goes down. And thus it tends to lose its validity as a measure of cardiovascular risk. And in fact, the lower it is, the more likely there is cardiovascular risk, because it tells you there is greater stiffening and calcification of the aorta. Hence, the wider pulse pressure, which probably is much more accurate because it takes into account higher systolic and lower diastolic. So I tend to move away from the diastolic in my patients who are over the age of 50, 55 years and focus more on systolic and pulse pressure. But for simplicity, the systolic gives you the same message as the pulse pressure. So I'm not a big diastolic fan unless the patient's younger. As far as the choice and dose of medications, I think it is unequivocal at this particular point that drugs that modify the activity of the renin-angiotensin system will and continue to be the foundation for which we add other medicines. I think, as we have all pointed out, individualization of blood pressure goals is most important, and to listen carefully to your patients if they do not feel well as you lower their blood pressure. Again, that could be medication toxicity, but it also could be a lower level of blood pressure. And let's agree, we're all different. There's some 80-year-olds, we can easily lower the blood pressure to 120 and they feel nothing. And then there are some that feel dreadful when you lower it to 140. And of course, there may be issues related to pseudo hypertension and accuracy of blood pressure measurements in people with calcified vessels. But I think, too, some of the other important decisions revolve around how to combine therapies to protect against progressive vascular disease. One of the conversation points that we brought up earlier in this series of talks is the distinction between utilizing a thiazide diuretic, for example, versus a calcium channel blocker in people who are already on an ACE or an ARB. I mean, that's an important consideration. Or, as I often do in my practice, give all three, especially if it's available in a single pill combination, which I know you all have great opportunity to do in India, which is a huge advantage over us in the US. But I think there are many facets of these conversations which are important. I think the real questions are which ones do we need to review in more detail for our audience listening in today? Because I think all the points were very important. Again, there's so much perspective around the table. A final point about the renal artery disease. I have to be honest with you. It is rare that I identify renal artery lesions that need surgical correction. I can count on one hand in nearly 40 years of clinical practice where changes in creatinine signal to me a concern, and then I do an imaging study and I find something that needs to be done. It just doesn't happen anymore. And I don't know why. Maybe we're using more statins. Maybe we're better treating our patients earlier with blood pressure medication. I don't know what the reason is. For some reason, most of my complicated hypertension, and I know we've discussed this in prior sessions, it's really related to the adrenal gland and blocking, aldosterone. So, I think, again, I just can't, I can count on one hand the number of people that I've had who've required a surgical angioplasty or percutaneous angioplasty. It just doesn't happen. I don't know why.
I couldn't agree with you more, Dr. Wire, when you say this, because we all find maybe perhaps use of statins. Looking at the other aspect that you just touched, yes, there is a shift actually. Whereas initially, if you look at the earlier times when hypertension started getting attention as a disease entity, there was more emphasis on diastolic hypertension. But as we went on, we realized that it's the systolic hypertension which is more deleterious. And as Dr. Matthew Wire said, elderly people have more of systolic hypertension. But I just recollect actually, last week I had a medical student actually came to me and he distinctly told me, of course, obviously he was young, so he has a diastolic hypertension. And he did tell me that his blood pressure, he says, whenever I stand up, my blood pressure is more when I sit. So it's opposite of what he's been taught in the medical school of orthostatic hypotension. And then I had to tell him this is the distinctive feature of an essential hypertension. So hypertension, has very distinct and very different presentations, and one has to, as Dr. Deodatta said and Dr. Matthew Wire also said, the individualization of a blood pressure, actually, sometimes we tend to be very drug-centric. In fact, the AllHeart study showed us that it's the numbers, the more better control of blood pressure that you achieve, the greater are the benefits to your patient. So it may not be a bad idea to be drug-centric or combination-centric, as Dr. Wire said, that most of our patients are today on combinations, but the numbers also are important issues and how far to go. I think we did have a very useful discussion. Dr. Tiny, any last-minute take-home message, any thoughts from each one of you three? And before I hand over to Onkar Swami, because we still have 4 or 5 minutes. So Dr. Tiny Nair and then Dr. Shubhankar Chaudhary, any take-home message for the audience?
So, can I ask a couple of questions to Dr. Matthew? One thing I wanted to know, there's a recent NEJM publication regarding use of chlorthalidone in patients with a lower GFR to control the blood pressure, in addition to loop diuretics, which they were continued. So what's your take on that, whether we should add a chlorthalidone to that particular combination? And the second question I wanted to know is that we are using now SGLT2 inhibitors in patients with non-diabetic CKD only for renal protection or renal preservation. So do you think in the future that would be an addition to the ARBs as a routine therapy for CKD?
So as far as as far as chlorthalidone goes, we actually covered this before. I'm a big believer in thiazides. And I
was going to tell you this, Dr. Wire, that Dr. Wire, he actually told us about this study before it was published. And in one of the earlier webinars, it was a month before actually this. So carry on, Dr. Wire, please.
Yeah, I was on the Data Safety and Monitoring Board and actually reviewed the NIH grant for Dr. Rajiv Agarwal, who's a close colleague friend of mine. Not that that played a role in my reviews. No, I've been a big fan of thiazides. Thiazides do help lower blood pressure in people with chronic kidney disease. There's absolutely no question. The difference between chlorthalidone and hydrochlorothiazide, I think in large part is related on potency. I mean, chlorthalidone is 2 to 3 times more potent. So, I think it's up to you in terms of the availability of using one or the other. You just have to remember, if I'm using 25 of chlorthalidone, it's like maybe 50 to 75 milligrams of hydrochlorothiazide or vice versa. But it does work. I will say this, the one issue in Dr. Agarwal's study, there is a little bit more risk for AKI, but that's why we follow the creatinine. It's always reversible, but it's a very useful tool. So it's interesting. I've come full circle. I remember coming to India with actually probably MCure 20 years ago. And we were all putting down thiazides and talking more about calcium blockers as an alternate strategy. I think we're coming full circle now, and we're realizing we often need all three, with a RAS blocker, obviously. Thiazides are having a renaissance in clinical practice because for some strange reason, they work very well in lowering blood pressure in people with calcified blood vessels. And we still don't know why. And it's not related to changes in blood volume. We know that. So there's a vascular effect. And there's also an effect that appears to be independent of the sodium chloride co-transporter in the distal convoluted tubule of the kidney. So we're learning. So that's why I'm saying I continue to be a very big fan of using thiazide diuretics in clinical practice.
What's your take on SGLT2?
SGLT2s, 4 to 5 millimeters of mercury, they lower blood pressure regardless of the GFR. And that's pretty consistent. They are completely GFR independent in terms of their effects on blood pressure, weight loss, kidney protection, heart protection. The GFR is not an issue. And of course, they're now well studied down to a GFR of 25, and there's another study coming out down to a GFR of 20. So, they do lower blood pressure. They're not as robust as some of the other drugs, but they will help contribute. And so you'll see an effect.
And it looks like their blood pressure lowering ability is far more in Asians for us compared to the Westerners, SGLT inhibitors, blood pressure lowering effect.
Yeah, I wish we knew more about how these drugs work. It's fascinating. It really is. And it's like the thiazides. We don't know how they work.
If there is no other comment from the expert panel, let me thank Dr. Matthew Wire for these 6 series of webinars that we have had, Dr. Wire. It's been a scintillating experience, very educative, very open discussions we have had. And I must thank the 3 panelists from across the country, Dr. Tiny Nair, my good friend from down south, Dr. Deodat Shefakar for making this lovely discussion today from Maharashtra, and Dr. Subhankar Chaudhary from the endocrinologist from Kolkata. So let me hand over for the last couple of minutes to Onkar Swami as we thank all the delegates for having been with us for all these 6 webinars. And I must thank AmCure for so consistently and persistently actually having the hypertension conclave over the last 10 years. Hopefully COVID will end, and we will have, we'll come back to the live hypertension conclaves that we enjoyed. I still remember the first one, since it's a Pune-based company, we had it in Pune, and then we had it in various other places. So Onkar Swami, please, for the concluding remarks.
So from my side, thank you very much, Dr. Wonder, and all the panelists and facilitators. Matthew Wire. I really enjoyed. Thank you.
Thank you, sir. Thank you, sir.
So thank you very much, Professor G.S. Wonder, sir. It's really been a privilege to have this program. It's 11th year, sir. We started in 2010, that you remember, in JW Marriott. And now this is the 11th year, and last 2 years we are doing online with a 6th module. I'm very hopeful that this year we will have in presence with all you faculty interacting with the largest delegate. So as we know, all good things have to end, and same as to this program. We have witnessing every month thousands of delegates across the country watching and witnessing this program. My sincere thanks to our course director, Professor Dr. G.S. Wonder, sir, consistently bringing this pulse of wisdom from the great faculties across the country and making available and making ready to in a simplified manner to all the delegates. I also thank Professor Dr. Matthew Weir. Every month he is joining us from US and delivering the lecture very nicely with bringing a new data and new evidence. I thank our faculty tonight, Dr. Professor Subhankar Chaudhary, sir, from Kolkata. I also thank my mentor, my personal guide, and my philosopher, Dr. Tiny Nair, sir, who have always been helping me since many, many years. I thank you very much, sir, being a part of this program. I thank Professor Devdutt Chafekar, sir, also been a mentor to me, making me understanding a lot of complex concepts of nephrology. Thank you very, sir, joining tonight and bringing some of the most important points in your discussion. With this note, we will stop here and we look forward for this year, sir. We'll have a physical meeting and let's look forward for that. With this note, let's thanks to everyone, all the delegates across the country, and we officially conclude Hypertension Therapeutic Conclave for this year. Thank you very much, sir.
Thank you very much for inviting me. I hope everyone stays well, and I look forward to coming back to India.
Absolutely.
In a number of years. I miss the food and the people. It's terrible.
Thank you.
Good seeing so many friendly faces again.
Good night.
Thank you.
Good night, sir.
Bye-bye,
Good night.
everybody. Good night.